Hi, today we're talking about the anti-estrogen medications, otherwise known as endocrine therapy. And this is used in about 75% of the women with breast cancer, whose tumors specifically express a protein called the estrogen receptor. That receptor makes them potentially exquisitely sensitive to these medications. These oral pills, which block the action of estrogen, are sometimes used in lieu of chemotherapy or in addition to chemotherapy. In general, they're incredibly well tolerated. Because of that, their activity and their importance in your treatment can easily be underestimated. The drugs are generally very well tolerated, but like all medications, have some side effects. The one thing I want you to completely understand is that you can let us know about these side effects and we can often work through them with you. As you'll hear in the video, there are actually several alternative medications which can sometimes be used. In addition, we also have some interventions we can use when you're experiencing a side effect to lessen the impact of that side effect on your quality of life. Most importantly, it's critical that you let us know if you're having that side effect so that we can be aware of it and potentially intervene. Together, I know we're going to make a very effective team treating your cancer. This video represents the views of Dr. Gary Frenette and not any clinic or hospital system. It's designed to supplement, but not replace, the written and verbal information provided to you during your office visits. It reviews common trivial side effects, as well as rare but life-threatening complications of therapy. The anti-estrogens and their use in breast cancer. Blocking the action of estrogen is one of our oldest and most effective strategies in the treatment of breast cancer. In fact, it is the first targeted therapy that used the specific characteristics of the cancer removed from the patient, that is, the presence of the estrogen receptor, to help direct treatment of the cancer itself. The estrogen receptor is a protein located in the nucleus of normal breast cells and in about 75% of breast cancer cells. When estrogen binds to the receptor couples or dimerizes with a second estrogen receptor. This dimer then activates DNA in the cell nucleus, promoting the formation of proteins, which then cause cell division and tumor growth. When estrogen, as you see in the target cell, binds to the estrogen receptor, the receptor has the ability to couple or dimerize, bind to DNA in the cell nucleus, and create proteins which promote cell growth. As you see on the right, however, the non-target cell contains no estrogen receptor, and therefore its growth is independent of the presence of estrogen. We'll now watch a short cartoon video showing the coupled receptor signaling the DNA to create protein, which then promotes cell growth. So blocking the action of estrogen can help kill breast cancer cells that contain the estrogen receptor. And there are three major classes of drugs which are used in this way: Tamoxifen or Nolvadex, the aromatase inhibitors, anastrozole, letrozole, or exemestane, and Fulvestrant or Faslodex. We'll now review how each of these drugs work to block estrogen activity in breast cancer. Tamoxifen is structurally similar to estrogen. It binds very weakly to the estrogen receptor. It blocks estrogen in the body from binding to the receptor. Since it only binds weakly to the receptor, and the receptor, when bound to tamoxifen, does not have the ability to dimerize or couple, the action of estrogen on the breast is blocked. However, tamoxifen can promote estrogen-like activity in other organs of the body, such as the bone, the uterus, and, for example, for cholesterol formation. So tamoxifen is used in prevention of breast cancer in patients who are considered at high risk, for example, patients with a strong family history but no personal history of breast cancer. It can be used in pre-invasive breast cancer, such as ductal carcinoma in situ, after appropriate local therapy. It can be used in invasive breast cancer in both premenopausal women and postmenopausal patients in an attempt to prevent the cancer from going elsewhere in the body. And this drug works equally well in both groups of patients, since it blocks the receptor which is present in the tumor of both age groups, at least potentially. When used in this way, the treatment is called adjuvant endocrine therapy. However, this drug can also be used neoadjuvantly, that is, prior to surgery, to try to help shrink the cancer. It's also used in widespread metastatic or stage 4 breast cancer in an attempt to shrink the cancer in addition. Tamoxifen, remember, is only effective in estrogen receptor positive cancer, and that in fact is true for all the drugs we're discussing today. Tamoxifen has both positive and negative side effects, primarily based on the fact that it acts similarly to estrogen in non-breast tissue. Therefore, like estrogen, it can slightly increase the risk of uterine cancer or slightly increase the risk of blood clots or stroke. However, it reduces the risk of very common problems, including heart attack by decreasing cholesterol, and also osteoporosis by promoting bone strengthening and growth. Other important points regarding tamoxifen include the fact that there's a slightly increased risk of stroke, as I mentioned, ovarian cysts but not cancer, hot flashes, and cataract formation. Certain drugs, such as certain antidepressants, may reduce the activity of tamoxifen. Those should be discussed with your oncologist. You should also have yearly pelvic exams while on tamoxifen, and for all the drugs we're discussing today, you must avoid pregnancy and breastfeeding. Overall, however, this drug is extremely well tolerated by most women and has really saved countless lives of women with breast cancer. The second class of drugs we're going to discuss today are the aromatase inhibitors. These include anastrozole, letrozole, and exemestane. All three of these drugs block an enzyme in your body called aromatase. That enzyme is responsible for making estrogen in your body. Therefore, by blocking this enzyme, the amount of estrogen in your body is greatly reduced, and therefore the cancer cell estrogen receptor cannot be activated. Without the ability of that receptor to be activated, the cancer cell cannot proliferate, and the cancer cell is therefore more likely to die. The aromatase inhibitors block the enzyme aromatase. This is present in the ovaries, but also in the fat, liver, and muscle. The aromatase inhibitors cannot block the large amount of aromatase present in the ovaries. Therefore, the ovaries must be inactive for the drug to be effective. That is to say, this drug is only effective in postmenopausal women or women whose ovaries are no longer functioning. In postmenopausal patients, the aromatase inhibitors, with or without sequential tamoxifen, were slightly better than used when compared to tamoxifen alone at preventing breast cancer recurrence. So clinically, the aromatase inhibitors are used once again for prevention in patients considered at high risk but with no personal history of breast cancer. They're also used in pre-invasive breast cancer, such as ductal carcinoma in situ, after appropriate local therapy, such as surgery and radiation. They're used in invasive breast cancer in a preventative fashion, that is, adjuvantly, after appropriate surgery in postmenopausal women, to help prevent the cancer from traveling elsewhere in the body. They can be used prior to definitive breast cancer surgery in order to try to shrink the cancer prior to surgery, that is, in a neoadjuvant treatment. And once again, they're also used in the treatment of metastatic or stage 4 widespread breast cancer. The side effects of these drugs primarily relate to estrogen deprivation. They have no estrogen activity on other organs, and therefore the side effects differ from tamoxifen. The major side effects of the aromatase inhibitors include an increased risk of bone loss, a slightly negative effect on cholesterol, muscle or joint aches can be increased, and hot flashes and night sweats are slightly less common than that seen in tamoxifen. The third class of drugs we're going to discuss today is called Fulvestrant or Faslodex. Faslodex is a pure anti-estrogen. Like tamoxifen, it binds to the estrogen receptor and prevents estrogen from binding to it. However, unlike tamoxifen, it binds to the estrogen receptor very strongly, so strongly that it does not act like estrogen in any way in the body. When Faslodex binds to the estrogen receptor, it inactivates it and causes the receptor to be degraded within the cell. Since once again the action of estrogen is critical for the life of the cancer cell in estrogen receptor positive breast cancer, Fulvestrant promotes cell death. So Faslodex is generally used in the setting of metastatic or stage 4 breast cancer. It may also occasionally be given in other circumstances when the side effects of the other drugs, such as blood clot risk or osteoporosis, are prohibitive. Unlike tamoxifen and the aromatase inhibitors, Fulvestrant is given, however, as an injection on a monthly basis after 3 initial injections are given every 2 weeks apart. So unlike tamoxifen and aromatase, which are taken by mouth, Fulvestrant is an injection given into the muscle. Fulvestrant is also well tolerated by most patients. Some side effects include, predictably, injection site pain. This drug may need to be avoided, for example, in patients on blood thinners. Hot flashes and night sweats can be seen due to its anti-estrogen effect. Nausea and abdominal pain are very rare side effects of this medication. And patients must avoid pregnancy and breastfeeding while taking this medication, which is similar to all the medications we've discussed today. The last topic I'd like to discuss is restoring anti-estrogen sensitivity to breast cancer. That is, especially in the setting of widespread breast cancer, at some point the anti-estrogens become less effective. When that happens, a drug called everolimus or Afinitor has been shown to restore sensitivity to the anti-estrogens in about half of all cases of patients with estrogen receptor positive cancer. This drug, everolimus, is an mTOR inhibitor, which is a mechanism cancer cells use to evade the action of anti-estrogens, that is, the mTOR pathway. By blocking this pathway, sensitivity to the anti-estrogen such as exemestane may be restored. So everolimus is a pill taken daily. This is a treatment that would only be used in estrogen receptor positive patients who have failed anti-estrogen therapy and have widespread or stage 4 disease. And although it's well tolerated in most patients, it does have more potential side effects than the anti-estrogens, which can include lung inflammation or pneumonitis, usually about 2 to 6 weeks after initiation, an increased infection risk, mouth sores, diarrhea, and rarely kidney failure. Let's now review some frequently asked questions with regard to the anti-estrogens. Which anti-estrogen is best for me? Well, the answer depends on many factors, including the stage of your disease, your menopausal status, and your medical history. Sometimes the medications are given sequentially to complete your therapy. For example, an aromatase inhibitor may be followed by tamoxifen to complete a 5-year course of treatment. Your physician will discuss these issues with you in more detail during your meetings. How long should I take these medications? Well, for patients with invasive cancer who are taking the drug to prevent spread of the disease elsewhere in the body, 2 studies have suggested benefit to 10 years of tamoxifen compared to 5. For patients taking aromatase inhibitors, 5 years of treatment is still the standard option. Patients with widespread disease, on the other hand, will take the medication as long as it remains effective and well tolerated. As we've heard, this specific group of patients, when resistant to the antiestrogens, may also benefit from the drug called everolimus. I've heard I will gain weight on these medications. Is that true? Well, in large double-blind prevention studies, that is, where neither the doctor nor the patient knew whether they were taking the anti-estrogen pill or a placebo, there was actually no significant difference in weight gain between these 2 groups. I have heard these medications cause depression. Once again, there was no significant difference in depression in the studies that I've discussed above. Well, but I know patients or other friends on these drugs that have become depressed or gained weight or lost weight. Well, regardless of how you're treated, there's a natural tendency to become depressed and perhaps overeat or undereat following a diagnosis of breast cancer. What surprises many people is that this often occurs after aggressive treatment, that is, surgery, radiation, and/or chemotherapy is completed. Well, what could I do if I get depressed after therapy? We believe it's vital to have a support counselor involved in your care from the time of your diagnosis going forward. The anxiety and stress that you're experiencing can be managed, often without drugs if properly recognized and treated. Please be forthcoming with your medical team regarding these issues during your treatment and wellness visits. I feel more joint and muscle pain on these medications. What can be done? Well, this is a known side effect of the medications, especially the aromatase inhibitors. There are instances where the drugs need to be switched, since other drugs, even in the same class, may not have the same effect on the given individual. We've also found that frequent stretching exercises are invaluable and have produced a video for our patients expressly for this purpose. Also, this side effect does tend to wane over several months and therefore improve. But once again, I can't overemphasize the importance of stretching and modest exercise during this period. It can have a dramatic effect on the joint and muscle pain you're experiencing. They may not be completely related to the medication itself, but simply decreased activity during the aggressive portions of your treatment. What can be done about hot flashes? Several interventions may be necessary, which include natural remedies such as lifestyle modification and acupuncture. Some medications have also been shown to reduce the severity and frequency of hot flashes, such as gabapentin or Neurontin, or drugs which are antidepressants known as Effexor. What can be done about pain with intercourse? This symptom is often caused by vaginal dryness due to estrogen deprivation. Many oncologists consider intravaginal estrogen suppositories to be safe due to very low systemic absorption of estrogen beyond the vaginal walls. This treatment can also dramatically improve this common problem. How much will these anti-estrogen drugs really help me? Do I really need them? These drugs can have a dramatic effect on survival, often more than even chemotherapy. Ask your doctor about the outcome data specific for your cancer with the use of these medications. and I think you'll be impressed by their dramatic activity in breast cancer.